I'll be talking today about the pitfalls to avoid in the management of short stature. And I will present some common scene that we see in the pediatric clinics, where it is an everyday scenario. The parents come worried and tell us, my child is the shortest in class. My child has delayed puberty. My child hasn't grown a bit in the past 2 years. Or a depressed child comes to our clinic and tell us, I'm being bullied in class. I'm so sad. I was kicked out from the sports team. And this is the pediatrician in his clinic asking himself these questions. Is the child really short? And if he or she is short, is it a normal variant or pathological? Is it genetic or chromosomal? Is it nutritional or chronic illness? Is it psychological or skeletal or endocrinal? So this is my agenda. I'm gonna speak about the definition of short stature, the etiology, some practical algorithm that we can use for proper and fast diagnosis of short stature, and we will discuss some pitfalls to avoid in the diagnosis and the treatment, and we will touch on the approved indications of growth hormone therapy, and all these through an interactive case presentations. So let us speak first, when do we say that the child is short? Let me present to you this scenario. Ahmed is 7 years old. He's coming complaining of short stature. His height is 109 centimeters. 1 year before, he was 106 centimeters, and 2 years before, he was 103 centimeters. And you can see the plotting here on the growth chart, the Egyptian growth chart. The mother's height was 160 centimeters and the father's height 170, and we calculated the mid-parental height to be 171.1 plus or minus 5 centimeters. And as you see here on the growth curve, we have plotted the heights of the mother and the father. And so let me ask you this question. How many criteria in Ahmed's anthropometry to tell that he is short? Does Ahmed have 2 criteria or 3 criteria or 4 criteria? Please choose one of the answers and submit. Yes, the child is really short because he has 4 criteria of short stature. First, his height is below -2 standard deviation score or below the 3rd percentile. Second, the height is less than the genetic potential target. He is 13 centimeters away from the mid-parental height, and it is enough to be 1.6 standard deviation away to be far from the genetic potential. The third criteria is that the growth velocity is only 3 centimeters per year, and if it is less than 4 centimeters per year, this child is short. And the fourth criteria is that there is height deflection crossing 2 centiles. So actually, Ahmed has 4 criteria of short stature, and this is the correct answer. So the key message number 1, please avoid these pitfalls. Do not wait the child is below the norms for age and sex. If the child is crossing 2 height centiles, this warrants investigation. Do not miss documenting the child's anthropometric data in each clinic visit. Do not forget to compare the child's height with the parent's height. And how would we calculate the mid-parental height? We add the father's height plus the mother's height. And if a boy, we add 13. If a girl, we subtract 13. And then we divide by 2. So we get the mid-parental height. Second, we will move to the etiology of the short stature. Is the etiology the same across the life cycle? No. In the fetal life, where the child attains 30% of the adult height, the uterine environment and the maternal environment is very important here for the proper growth of the child. During infancy, the child attains 15% of the adult height. Nutrition, good health and happiness, thyroid hormones are all very important. During childhood, the child attains 40% of the final adult height, and here growth hormone has a very important role, together with the thyroid hormones, good health and happiness, and the genes. During puberty, the child attains 15% of the final adult height, and here a synergistic effect between the sex steroids and the growth hormone is very important. So, if we try to put a differential diagnosis for short stature, we can say that short stature is either a normal variant, which is the most common, and it is either familial short stature or constitutional delay of short stature. Second, the next common is the non-endocrine causes, which can be due to chronic disease or malnutrition, dysmorphic syndromes, intrauterine growth retardation, or skeletal dysplasia. And third common are the endocrine causes, where the causes may be growth hormone deficiency or resistance, hypothyroidism, Cushing syndrome, parathyroid, and vitamin D disorders. So let us agree on some practical algorithm for proper diagnosis of short stature. We can say that if we get a child with short stature whose height is below 2 standard deviation score, we can see, does the child has no dysmorphic features and no disproportion, then he can be a normal variant, chronic disease, malnutrition, intrauterine growth retardation. He may have received some drugs like corticosteroids. It may be due to psychological factors, or it may be due to endocrine causes. But if the child, we look into his face and we find some dysmorphic features, we do some chromosomal analysis. If there are chromosomal aberrations, it can be Turner syndrome or Down syndrome. If no chromosomal aberrations, it can be a Noonan syndrome or a Russell-Silver syndrome. So what if the child has disproportionate short stature? He can have skeletal dysplasia or inborn errors of metabolism. Let us apply this algorithm through some case scenarios and discuss some pitfalls to avoid during the diagnosis and the treatment. So let's see this case scenario. Nabil is a 15 years old boy. He's coming complaining of a short stature since the age of 6 years. He has also delayed puberty. The mother has had her menarche at the age of 15 years, and his uncle had delayed growth spurt, but later he catched up his growth. We calculated the mid-parental height, and we found it to be 170 centimeter. You see here on the right, on the growth chart, we have plotted all the data of the growth of Nabil, and also we have plotted the mid-parental height range here. General examination is normal. He has proportionate short stature, and when we examined his puberty, he has just started his puberty. He has Turner stage 2. We did him some investigations. The basic lab investigations are normal. The celiac screening is negative. The thyroid profile is normal. He has done growth hormone stimulation test. The peak is normal. He has done gonadotrophin releasing hormone stimulation test. The FSH, LH are low. The serum total testosterone is low. The bone age is 11 years and the height age is 11 years. What do you think is the diagnosis of this child? Do you think this child has familial short stature because his uncle had history of delayed growth? Or do you think he has constitutional delay of growth and puberty because the mother had history of late menarche? Or do you think he has pan-hypopituitarism because Ali has delayed growth and puberty? Yes, as many of you have recognized, this child has constitutional delay of growth and puberty because of several reasons. First, he has positive family history of constitutional delay of growth and puberty. The mother had had her menarche late, and his uncle catched up his growth late. And because his bone age equals the height age, and this is a very important clue for diagnosis of constitutional delay of growth and puberty. So the follow-up, as you see on the growth charts, this patient has accelerated his growth late in the puberty, and has reached a normal final adult height, which is coincident or matching with the mid-parental height. So what do you think the treatment of constitutional delay of growth and puberty would be? It would be just reassurance. Growth hormone therapy is not needed for this child, but sometimes in these cases, if there is delayed puberty, we may need a small dose of androgen therapy to boost and start puberty in very selected prepubertal cases. Okay, let us always remember that there is normal variation of the normal growth and puberty. Not every child attains a puberty and attains the growth spurt at the same age. There is a normal variation. And during puberty, we need the synergistic effect of sex steroids together with growth hormone. So if any child presents with delayed puberty, it is usually also accompanied with short stature. So the key message here, please avoid these pitfalls. Do not forget to exclude the normal variants of short stature like constitutional delay of growth and puberty and familial short stature. Remember that growth hormone therapy is not needed in these cases, and the clues for the diagnosis of constitutional delay of growth and puberty is that there is positive family history of the parents' delayed growth and that the bone age equals the height age. And concerning the familial short stature, these children have normal growth velocity. They do not have deceleration of height or weight, and there is less than 1.6 standard deviation score difference between the child's height and the mid-parental height. And in the familial short stature, the bone age equals the chronological age. And as you see, these two growth charts differentiate the constitutional delay of growth and puberty. The child is normal, then decelerate, then accelerates and becomes normal at the end. But in the familial short stature, the child is short and respects his growth channel all until the final adult height. He is also short because his target height is also short. So the growth charts help us always to differentiate the common variants of short stature and to differentiate between the constitutional delay and the familial short stature. So if you go back to the differential diagnosis, we are here in the normal variance, which is the most common, the constitutional delay of growth and puberty. And if we apply the algorithm that we said, yes, this child is not dysmorphic, he's not disproportionate, and the first cause to exclude is the normal variant, which was this case. So let's move to the next case. The next case is Ali. He's 12 years old. He has long-standing obstructive uropathy, developed chronic renal insufficiency. He's coming to us complaining of short stature since the age of 5 years. His height, as you see, is below the third percentile or -3 standard deviation score, and also his weight is below the norm, but the mid-parental height is normal. He is prepubertal, and his bone age 7.5 years, and his height age is 9 years. So the diagnosis of growth failure in chronic kidney disease is multifactorial. We have to search for the anthropometry and for the biochemical and investigations. You see here, any child who has systemic illness, the height decelerates and also the weight decelerates. This is different from the child who has an endocrinal cause. The height decelerates, but the weight is normal or even increased. So it's very important to look to the anthropometry, to the puberty, to the bone age, and to the biochemical assessment. What about the labs of this child? This child, as you see the labs here on the left, he has chronic renal insufficiency, high creatinine, and low glomerular filtration rate. He has evidence of bone mineral disease, hypocalcemia, hyperphosphatemia, vitamin D deficiency, and secondary hyperparathyroidism, as you see here from the labs. His thyroid profile is normal. His celiac screening is negative, but he has anemia. As you see, the hemoglobin is 9, and he has hypoproteinemia. You see the albumin is low. He has also metabolic acidosis. The bicarb is low, and the pH is low, and his growth hormone peak is 13. He has growth hormone insensitivity and IGF-1 deficiency. So in children with chronic kidney disease, what is the cause or the pathogenesis of growth failure? Is it growth hormone deficiency? Is it growth hormone insensitivity? Or is it IGF-1 resistance? Yes, you are right. it's usually a growth hormone insensitivity due to the malnutrition, the mineral and the bone disorder, the metabolic acidosis, the anemia, the water and electrolyte losses, the steroid treatment. All these lead to growth hormone insensitivity. So this is the correct answer. Growth hormone insensitivity is the cause of growth failure. So I want to ask you again, the following is true regarding the optimization of growth in a child with chronic kidney disease. Would we start growth hormone therapy without delay in this child? Or should we correct the CKD related limiting factors first? Or do you think that nutritional management has a minimal role? What do you think is the correct answer? Yes, as most of you has said, we should correct the chronic kidney disease related limiting factors first, like the protein calorie malnutrition, the metabolic acidosis, the electrolyte disturbances, the dehydration, the mineral dysregulation, and the secondary hyperparathyroidism. And also nutritional management is important. And after we do that, we give the growth hormone therapy. It's important, and growth hormone therapy will help to catch up the growth. The maintenance of the growth channel will help that this child has a normal timing and normal intensity of puberty and will reach adulthood with an acceptable final adult height, with a normal body composition, and with a good physical and mental energy. And remember that growth hormone stimulates growth whether if it is given pre-dialysis or on dialysis or after renal transplantation. And this systematic review proves that if we give growth hormone in a dose of 45 to 50 mic per kg per day, we can get normal growth. And this is approved by both the FDA and the European, the EMA, in the dose that we have just mentioned. So please avoid these pitfalls. Do not forget that non-endocrine causes of short stature are more common than the endocrine causes. Remember that growth hormone therapy is approved by the FDA and EMA in chronic renal failure. Do not forget to exclude chronic disease in any child with short stature, and do not miss the growth retardation of the height and the weight, which occurs in 60% of the cases with a chronic renal failure, and do not ignore the correction of metabolic abnormalities before starting the growth hormone therapy. So if we apply the differential diagnosis, we have here discussed a case with a non-endocrine cause, which is the next common after the normal variant. It's a chronic disease due to the chronic renal failure. And if we apply the algorithm, yes, this child was not dysmorphic, not disproportionate, he's not normal variant, he has a chronic disease, which is a chronic kidney disease. So let us move to the next scenario. Amal is a 5-year-old girl. She's coming complaining of short stature. She had a birth weight of 1.5 kilograms, but she was full term. She doesn't have any chronic disease or malnutrition. Her height, as you see on the growth curve, is below the third percentile, and the height standard deviation score is -3 standard deviation score. The mid-parental height is normal, but Amal has not catch up her growth over the previous year. She remained short. She has no dysmorphic features. She is proportionate. The bone age is 3.5 years at a chronological age of 5 years, and all the baseline labs are normal. So the karyotype is 46XX normal. The thyroid profile is normal. The celiac screening is negative. She has done a growth hormone stimulation test by clonidine. The peak is 11.2, which is normal, but her IGF-1 is low. What do you think the possible cause of short stature in this child? Does she have familial short stature, genetic short stature, or because she was small for gestational age? Yes, because she was small for gestational age. What is small for gestational age? It's when a child, the birth weight or the length is at least 2 standard deviation below the mean for gestational age. And actually, this is 5% of the neonates are born small for gestational age. But only 10% of these born small for gestational age remain short through childhood and adulthood. 90% they catch up their growth. So what are the guidelines for growth hormone therapy in small for gestational age? Which statement is true? Do we start growth hormone therapy shortly at birth to prevent short stature? Do we wait for catch-up growth for 2 to 4 years? Or do we wait for catch-up growth for 1 year? Yes, we should wait for catch-up for 2 to 4 years. This is the guidelines. And as you see here, when Amal, we gave her growth hormone in a dose of 0.035 mic per kg per day, the follow-up growth, and we followed up the growth velocity every 4 to 6 months, there is catch-up growth, the IGF-1 is normalizing, the bone age every year is improving, and she has catch up her growth and her height is normalizing. But we have to take care of the long-term health risks for children born small for gestational age. They have higher risk of metabolic syndrome, obesity, insulin resistance, high blood pressure, dyslipidemia, coronary heart disease, and also other possible health risks would be precocious puberty, gonadal hypofunction, testicular cancer in males, polycystic ovarian syndrome in females, low muscle mass, low bone mineral density. So we have to take care of all these health risks. And remember that growth hormone is approved by the FDA and the EMA since 2001 in the dose that we have mentioned from 35 to 70 mic per kg per day. So the key messages here, please avoid these pitfalls. Do not miss to document the birth weight and the birth length for every newborn. Remember that growth hormone therapy is approved by FDA and EMA in small for gestational age. Do not postpone growth hormone therapy more than 2 to 4 years in children born small for gestational age if no catch-up growth occur. Do not give growth hormone dose less than 35 mic per kg per day. Do not miss screening small for gestational age for the long-term complications. So if you go to the differential diagnosis, we are here in a non-endocrine cause, which is the next common, the intrauterine growth retardation. And if we go back to the algorithm, we are here, the child is not dysmorphic, not disproportionate, and the cause is intrauterine growth retardation. Let us move to the next scenario. Hala is a 13-and-a-half-year-old girl. She has delayed puberty. She has short stature. She has past history of low birth weight. And as you see here in the picture, she has swelling in the dorsa of the feet at birth. And when we examined her, we found that she has a webbed neck. What investigation is diagnostic for this case? Is it growth hormone stimulation test, as she may have growth hormone deficiency? Is it karyotype? Is it bone age? Yes, it is the karyotype, because this case got out to be a Turner syndrome, 45XO. And as we all know on the screen, these are all the facial and the characteristic features of Turner syndrome. But short stature can occur in absence of all these features. So remember that Turner syndrome is approved by FDA and EMA for growth hormone therapy since 1997 in a dose of 47 to 67 mic per kg per day. So the key message here, please avoid these pitfalls. Do not miss doing a karyotype in any short female, even if there are no features of Turner syndrome. Remember that growth hormone therapy is approved by FDA and EMA in Turner syndrome, and do not forget to give estrogen and progesterone for initiation of puberty. Do not forget to manage other comorbidities for Turner syndrome, the cardiac, the renal anomalies, the thyroid, or the celiac disease. Do we have more time for
Yeah,
another
Dr.
case?
Shereen, we are approaching the end of time.
Okay,
So if
so
you
can you
can
move
try
me
to
please to the
conclude.
conclusion? To the
Yes.
conclusion, please. So skip some slides and go to the conclusion, please. Yes, please skip. Again. So, yes, the take-home message. Yes, please. Next. Yes. Short stature is challenging to the pediatrician. It has a rich variety of phenotypes and a wide range of pathogenesis. So if we apply, yes, this algorithm that we have said, that normal variants are the most common, the non-endocrine are the next common, and then come the endocrine cause. And you have here all the causes that we have mentioned before. Next slide, please. Remember that all these are the approved indications for growth hormone therapy. Next slide, please. Please avoid the non-systematic clinical approach. Always be systematic. Always plot the anthropometric data. Do not miss the dysmorphic features or the disproportion. Remember that common variants are the most common cause of short stature. Next, please. Never miss doing a karyotype. Do not delay growth hormone therapy. Do not miss monitoring children under growth hormone therapy. Do not forget compensating for multiple pituitary hormone deficiencies. Do not stop growth hormone therapy in the transition period in severe cases of growth hormone deficiency. And at last, please hope for an integrated care between the pediatrician and the pediatric endocrinology for optimum diagnosis and management of children with short stature. Thank you very much. I have been so pleased to be with you, and I'm ready to
Thanks
receive
a
your
lot, Dr.
questions.
Shereen.